Matt, thanks for joining me. You're an experienced radiologist, mainly in the musculoskeletal area now, in one of the big radiology practices. Can you tell us a bit about your background, just briefly?
Hi, Mark. Thanks for having me today. So, as you can tell from my accent, I grew up in the UK, and that's where I did my radiology training. I initially did surgery before seeing the light and converting to radiology. Having got to radiology, they quickly turned the light off so that we could see the images okay. Since doing radiology, I've developed an interest in musculoskeletal radiology, as you suggested, partly because I enjoyed doing orthopedics as a surgical trainee for a while. I'd mainly do MSK scans, sports medicine scans, rheumatology scans, and quite a few injections every day.
Mm. Now, things have changed quite a bit since I started practicing with radiology. It's all online. There's a lot more availability. What's changed most, do you think, from your point of view with musculoskeletal imaging in the last 10 years, let's say?
Yeah, so radiology as a whole has changed dramatically whilst I've been a radiologist. We've had the advent of PACS, which is a sort of basically an electronic picture system. So when I first started, X-rays were printed out, CTs and MRI scans were printed on film, and it would take a long time to look at them. You'd also be less accurate at picking up abnormalities by looking at individual images rather than scrolling through on a screen. So PACS is definitely the biggest thing probably to affect how we work. With other advances include sort of, new scan sequences. So we now have 3D scans, which can also help detect things that we couldn't see before, as well as increased detail. There's also scans have become much quicker. So a CT scan now may take less than a minute, whereas when I first started, it was several minutes. So you've got increased patient comfort as well.
With MRI scans, that's obviously what we do a lot of together. Is that's become more available? Seems to have become much more widely available as well.
Yeah, certainly in the UK, when I was training, there's much more readily available access to MRI for both specialists and where I was working in Bath before coming back to Australia for GPs as well. In Australia, MRI has been somewhat rationed by Medicare. The rationing has sort of loosened up a bit recently with more MRI scanners getting licenses and Medicare rebates now available for GPs for certain indications. So that's great. It also, by giving more licenses to radiology practices, it reduces the waiting time for patients, and also the providers are less likely to need to charge everyone a gap because there's more throughput.
That's certainly one thing that's changed in my practice is as MRI scans become more widely available, I use them more and more routinely now. So I guess that's a change of practice from my point of view.
Yeah, I think in the old days, it was unusual often to get an MRI before doing an arthroscopy, maybe, or unless you thought that there's something unusual. Whereas nowadays, I presume that most patients would have already had their scan before you decide whether or not they need a scope, and often GPs would be the ones that have requested that scan. So patients, do you see more patients coming to you that have already had their scans?
Yes, and we tend to screen people based on their referral as to whether they need an MRI scan before they see us. So we often arrange it ourselves before they see us. You're correct, yeah. Matt, what do you see as the main challenges with this knowledge explosion, the availability of musculoskeletal imaging? What are the main challenges from your perspective facing us?
So from a personal perspective, MSK radiology, as well as every other subspecialty of radiology, has the amount that we know, the amount that we can see, the different types of scans have just grown exponentially. So it's very hard to be expert at everything, and the days of the general radiologists are pretty much over. So for the company that I work with and with other big companies, we have subspecialty teams. So I predominantly do MSK, I do spinal work as well, and I do some general work. But if there's something that I don't know much about, or there's an abnormality that I'm not sure of, there's a colleague just a phone call away that I can show the scan to and see what they think. I think for radiologists that are working in small practices, then that becomes harder, and that they're expected to report far more variety of scans, which they may not have the same level of experience at. The other areas is just the amount of throughput with the increased access to imaging from GPs. We're doing far more scans every day. We train sonographers to do specialised musculoskeletal ultrasound that 10 or 20 years ago would only be done by the radiologist, and it allows us to look at their images. The sonographer can discuss the patient's symptoms with them and discuss with us what the abnormalities are and what we think is most relevant. Whereas in 10 years ago, we might have done half as much work because we were directly scanning every single patient ourselves.
So you've delegated a lot of the scanning to the radiographers, which makes sense.
Yeah.
And then you concentrate.
I think it's not just delegation, but certainly for general radiologists, if they've got an ultrasonographer that is experienced, then they're going to produce a better report because that person is technically better at looking at the patient and scanning them, acquiring the images, and then the doctor can use their knowledge to interpret the findings in conjunction with the history and the details the patient gives.
Do you find you're doing a lot more injections than compared to what you used to do?
Yeah, I do a huge number. It's something that I sort of subspecialize in. It's hard work. We've got a bit of a waiting list because of the amount of, particularly the spinal injections are very popular. But yeah, it really helps patients get through, particularly if they're waiting for surgery or there's a delay of surgery like we have at the moment with the COVID crisis. The one area of our work that hasn't really been affected, in fact, is injections. So I'm probably doing more now for patients that haven't been able to, they've had their joint replacement put off, so it helps them get through the next few months until elective surgery is really back to normal.
Just with regards to musculoskeletal imaging, with all this availability, what do you think is the least helpful imaging technique for different joints?
Yeah, it very much depends on the joint. One common area that we see is ultrasound for the knee. It can be useful to assess the soft tissue. So if you've got a patient that you're querying patella tendonitis or a quadriceps tendon tear or Baker's cyst, then that's fine. But if it's something deeper inside the joint, you won't be able to see that a meniscal tear or an ACL tear with an ultrasound. So I find often X-rays and ultrasound are a good baseline combination for looking at joints, but then often if the answer is not apparent from those tests, then often it's best to go to cross-sectional imaging, and ideally with MRI, which looks at the bone marrow, the cartilage, and the ligaments.
And with regards to the other side of the question, what's the most useful? We've spoken a bit about MRI scan. Do you think that's generally the most useful?
Yeah, I think so. I think, again, it's been probably underutilised in Australia. I remember coming here as a fellow back in 2009 and having to report CT scans of the lumbar spine, which I'd never seen before in the UK, because we'd just, why would you CT somebody when you can do an MRI scan which shows the nerves much more clearly? And, having said that, CTs are, you do get reasonable detail, but generally an MRI scan is ideal for most joints. CTs there's still a place for them, particularly with complex fractures or fractures that are going into a joint, to see how much of a step there is in the joint surface. So there is a place for CT, and we're increasingly using CT for preoperative scans to help with computer-assisted joint replacement and robotic surgery. And one of the areas that I specialise in is looking at dysplastic hips, so abnormally formed hips and abnormal rotation of the limbs. We do a CT rotational profile, which is a scan through the hips, the knees and the ankles. We can get 3D reconstructions of the hips, and all of that is less dose than a chest x-ray, which is incredible because a chest x-ray is really low dose. I'm not entirely sure how they manage to do it at such low dose, but it's great because a lot of these patients are young adults or even children. So, to minimise the radiation and get great detail is really good.
That's a good point, because a lot of people don't seem to be keen on CT scans because of the radiation, but they don't realise the radiation dose seems to have been dramatically reduced in the last few years. Yeah,
every year the newer scanners coming out with lower radiation dose, and they use clever software to really maximise the detail that we get from an ever reducing radiation dose. So what you had 10, 20 years ago would be multiple times more than it is now, and it needs to be put in perspective, really.
We're seeing a lot of ageing, which we would describe as normal because of the sensitivity of the scans. We're picking up stuff that really is sort of normal aging, I guess. How can you tell what's normal and abnormal? I guess it's a complex area, isn't it?
Yeah, I mean, there's from birth to death, there's a gradual change in how our joints look. From early infancy, the bones, the ends of the bones are made of cartilage. They then become ossified. As you get older, the cartilage on the joint surfaces becomes thinner, and you get what's called surface fibrillation, or sort of roughness to the cartilage. And the cartilage at the edges of the joint often becomes ossified. So we often, there's a sort of overlap between normal aging and pathological processes such as osteoarthritis. And we see patients who have had particularly meniscal tears that have taken out the shock absorber, as it were, from the knee, that they will then get accelerated cartilage loss, and their knee will then end up in that compartment, will look like a much older person's knee quite rapidly. Now it is very variable, and it depends on multiple different factors like the patient's activity and genetics, the cartilage makeup, and also the surgery that they've had.
So do you think that there's a sort of normal abnormal variant, like we're thinking about labral tears in the hip, for instance, where it seems that it's almost normal to have one, or as commonly to have one as not to have one?
I report a lot of hip MRIs, and it's unusual to see an MRI without a tiny labral tear. Whether equally we can see patients with extensive labral tearing that you think, that's bound to be the symptomatic cause for the cause for their symptoms, but they may have problems with their back that's causing their hip pain. So I think on scans we see a whole range of pathology and normal and abnormal appearances, and it always needs to be taken in conjunction with the clinical picture, which is where it's really important for the referrer to take a history, examine the patient, and put together what we've highlighted on the scan as abnormal areas with what the patient's history and examination suggests is the pain generator. Yeah.
So with GPs, obviously a lot of GPs will be watching this. What would you, if you had a single piece of advice with regard to musculoskeletal imaging, what would it be?
It's a good question. I think probably just if you've got somebody with pain that's not settling, then have a low threshold for starting off with an X-ray and an ultrasound, and if those don't show the abnormality, then to consider rapidly moving on to cross-sectional imaging, and ideally MRI if it's available. For most things would be the gold standard, and have a low threshold for referring on to a specialist if things aren't settling down. Occasionally we'll have bone tumours that aren't apparent on the initial imaging, or other serious things that could have cause accelerated arthritis, which can be dealt with at an early stage before they cause complications.
And the history given on the request form, do you find that that's sometimes a little bit inadequate and you need to flesh it out a bit?
So we've got the benefit on our MRI. I redesigned our patient questionnaire, so we ask patients some history. Often that's lacking as well, but I think, you're right. It's very important to have some history and to know which side of the joint the pain is on, whether it's on certain movements or whether it came on suddenly or gradually, if they've got night pain or other red flags. So the history is very important. It can affect the way that we do the scan, and particularly for spinal imaging and intervention, we regularly scan patients in their 80s and 90s that have got multiple level changes. So they've got nerve root impingement at multiple levels, facet joint arthritis at multiple levels, and often the request may just say low back pain or leg pain, but not specify which. So again, we ask our radiographers to take some history from the patient, find out how far down their leg their pain goes, whether they've got numbness, etc., etc. And that, so again, we compensate for the cases where there might be a lack of history on the request, but ideally, if it's on the request, then you don't have to rely on the radiographer to take that history, and it will end up with the patient getting the most appropriate recommendations for any further injections or surgery that they might need.
Interesting. And is there anything on the horizon musculoskeletal imaging wise that's exciting from your point of view?
I think as a whole, artificial intelligence is going to have a big impact in radiology. It's not really there yet. There are a few isolated projects and looking at lung nodules and things like that. But I think it's just a matter of time before scans will be assessed by the artificial intelligence module on your scanner. It will come up with a number of findings, and then it will be down to the radiologist to look through those and formulate a report. From the point of view of musculoskeletal radiology, the scanners are getting quicker, they're getting more detailed. I think that will continue going. I'd quite like to have a robot to do my injections for me. That'd be very nice. Again, it's probably possible, but not quite there yet.
Fantastic. Well, Matt, appreciate your time. That was very clear. And
thanks a lot, Mark.
Thanks again for sitting in on us. Thank you.
Okay. See ya.